Hello, I'm Ian Scales, you're watching TelecomTV, and I'm here at the Internet of Healthcare, where I'm going to be talking to Tim Omer, who is a patient advocate and inventor. And we're going to be talking about how bottom-up techniques can be used in the medical area rather than top-down mostly. Would that be a fair summation of your approach, Tim?
Yes, I completely agree. So the group I work with is a group of type 1 diabetics who go under the hashtag of We're Not Waiting, and they're taking existing technology that we already have available, freeing that information and better utilising it to manage our condition.
Okay, well let's take a slight helicopter view. How did you come to be a patient advocate?
Approximately a year or so ago, I discovered the We're Not Waiting movement of patients, some of the projects that they had done. It's very important to understand that these projects are completely open source. So a lot of the projects have all stemmed from similar products that have extended their ability. So the sharing of data, sharing of information has really been quite powerful. And I was very intrigued and interested in that. I wanted to better manage my condition. I saw they tackled certain needs but not others, and therefore I proceeded to build a mobile phone app, artificial pancreas system that utilised the community's work and also functionality that I required that would run from my mobile phone.
So open source medical information, I suppose you could say.
It's an open source medical algorithm from a team called OpenAPS that crunches the numbers and outputs medical suggestions. You also got open source hardware, how to pick up the blood sugar information for myself and interface with insulin pumps, and also the actual application itself, again all open source.
Right, that's amazing. Do you know, has anybody tried that before, or is this new stuff?
We've always had apps potentially being developed. We've always had medical devices with certain functionality. Unfortunately, this has always been the traditional top-down approach. So generally either not really catering for the patient's needs or very restrictive in how the information is shared and how we can actually process and utilise that information. The communities projects are very interesting because what we're doing, we're freeing the data. We're not necessarily saying how to use it, we make it available. And then other community projects take that data and do interesting things with it.
In terms of the patients though, do most patients have an understanding of how you would use the data that you're gathering and really get involved in it? Or really are we talking about people that have already got a lot of expertise who are working together on this?
I think you definitely have a 1% situation where we have like 1% of very motivated, potentially technical and interested kind of individuals that are producing solutions. And a couple of examples I can give would be the Night Scout system, what allows monitoring blood sugars remotely via a web page, and also the OpenAPS system, where it's an algorithm to crunch your data and give medical suggestions. Yes, these are developed by a smaller number of people with the correct skill, but the patients who can benefit from this and understand how it operates and therefore utilise it is much wider. But that's one of the challenges of that community. How do we make this available to others?
Yes,
exactly.
Yeah, and how do you disseminate it?
Well, a great example in the community has been with the Night Scout system. This is a very low risk project. So all we're doing is taking medical data, my blood sugar information, and putting it in more accessible locations, be it on a website or be it on a smartwatch. To do that, you do require some technical skills and also some soldering skills to build a device called an X-strip, where it kind of fits in a tic-tac box. The way the community's got around that is by gatherings where people come together, they share the skill and knowledge. We do not build the product for someone, but we empower them with the education and knowledge on how to construct that system and then how to utilise it afterwards.
And tell me, how easy is that to do? This is a little gizmo that will measure your blood sugars for you.
Well, from an actual soldering point of view, it's literally off-the-shelf components. So you just go to a website, very standard cheap components that you can purchase. Right. It's a soldering of a few cables, and the majority of the complexity will be the code that's written for it. But that's where the more kind of knowledgeable and expert people in that community develop that code. But one thing also very important to say, the code that is developed is open and is scrutinised. So we don't have just one person developing something and everyone utilises it in blind faith. There's many developers who then contribute and check and challenge that code.
Yes, challenge the code. That's really interesting. And how much does it cost somebody to build their own blood sugar measurement device? So
an X-strip device, what listens out to the signal of the CGM and sends it to your mobile, that box is approximately around about, I'd say, £40. Compared to the manufacturer's device, what is more in the around 600s, it's significant saving. Also makes it disposable. So I can now afford to have two and carry them around with me as a backup, where if I went with the manufacturer's device, I wouldn't be able to afford it.
Yeah, oh, that's fascinating. So what other areas can you have patients better integrated into the process of healthcare? I can see it with measuring your blood sugars and so on. That's relatively simple and easy to understand and not highly complex once you know the processes involved. How can you apply it more generally, do you think? Give us an idea.
Digital patient records, I think, are such an example where it's ridiculous that we do not have a system like this already available. As a patient, I should have access to this information, so when I require it, or when I'm requesting for information of that, I can easily accessibly get it and share it. You know, that's my data, I should have access to it.
Okay, and how will this, what are you aiming to do in the long run? I mean, one could see that if it's a bottom-up movement, you might try and either, I don't know, stimulate the system into including, you know, patient involvement much more, just by a process of shaming them, really. Or you might be looking at building it up into a movement that kind of bypasses the existing structures. Which way are you going on that?
Well, the really interesting thing about the community is that there was never a plan to build an artificial pancreas. It all started with modest projects with modest needs and solutions. And it was only the combination of those projects that ended up doing more complex solutions. So right now, I wouldn't say we're trying to conquer the world or do certain elements, but what we are finding is that now, as our projects are maturing, we're tackling more complex issues. We are potentially starting to see industry, therefore, taking notice and deciding to move quicker in certain areas. So we definitely don't want to compete against the industry. If anything, we want to fill that missing gap where we need the certain data or technology now. We're pioneering that, and then we publish the results and information, be that for more complex and advanced community projects, or be it for the industry to learn and adapt and adopt.
And can you see, I mean, the practical outcome of this could be the creation of more devices that are much more cost effective, presumably. That's one very real piece of low-hanging fruit that you can gain from this.
Most definitely. Some of the work that has been done by the teams who work on the X-Strip system, what's the Tic-Tac box and software, you know, one of the offshoots of that, the benefits, is not only do we now control the data, we don't have to have certain elements of the manufacturer's system, which significantly reduces the cost for us and therefore access.
Now, all of this is really interesting, and I wonder if it opens up spaces for new sorts of player as well. I mean, we all understand how hospitals work and so on, and they tend to be large bureaucratic entities which are located in a centralised spot, and we all understand that. Are we talking about a kind of virtualisation of, ideally a sort of virtualisation of the medical superstructure? Do you think, you know, are we going to have different sorts of players coming in as well, perhaps? I don't know, people like social networks and so on, actually enabling some of these communications to take place?
I think as a community, what the code information we publish, it's available, be it for private use, be it for further development, or be it for commercial use. So it's there. If someone's got an interest, they want to take it and they can utilise it, we're providing it. You know, we're happy for that to be done. I think that the movement itself is very unusual. It's something we've not really had before. Such cheap technology, well-educated and passionate individuals who are producing usable, basically, devices. And I think it's also one of the only paths where it is purely patient to patient. You know, the only outcome from this, the only goal is generally to improve the quality of life of the patient. And I don't really think we have many other care ways that actually put patient truly first.
Mm. Do you also have involvement from medical people as well, you know, qualified medical people? Do they get involved as a kind of sideline?
I've definitely spoken, and I'm very willing to engage and discuss those ideas. Typically right now it's very much an acknowledgement, but more kept at an arm's length and at a genuine interest. And I think we're definitely seeing that in the industry, but also in the medical kind of NHS sector as well. And I think this is just over time, you know, this will improve and get better. You know, it's not going to go away. Patients are not going to stop being interested in that condition, and technology is not going to suddenly get more expensive necessarily for what we're trying to utilise. So I think the borders will kind of break down over time. People will get used to more of the fact that there's such a thing as an empowered patient, and then we all need to kind of discuss and work out how do we care for such patients in the long run.
Yeah. That is really fascinating. Thank you very much, Tim.
Thank you.
Great stuff.